You might instinctively think of the elbow as, well, just a simple hinge, a basic connection between your upper arm and forearm.
That's common thought.
But if you actually peer beneath that apparent simplicity, you'll uncover really a true masterpiece of biomechanical engineering.
Absolutely.
It's not just a joint. It's genuinely pivotal for almost every intricate movement we perform with our upper limbs, whether it's lifting a teacup with precision or, say, delivering a powerful cricket ball with force.
Quite the range.
Today, on the Deep Dive, we're aiming to cut through the complexity to give you a definitive shortcut to becoming profoundly well-informed about this vital joint.
A worthwhile goal.
Our mission is to meticulously unpack its intricate anatomy, its truly fascinating biomechanics, and the common pathologies that, unfortunately, can affect it. This isn't just academic, is it?
Not at all. It's foundational.
It's a foundational understanding that is absolutely essential for any medical professional aiming for excellence in patient care. And to guide us through this intricate landscape, with his unparalleled ability to synthesize complex information into profound, actionable insights, we are privileged to welcome our expert guest today.
Thank you. It's a genuine pleasure to delve into an area of human anatomy that is both so fundamental and yet, as you say, so incredibly complex in its design and function. The elbow truly embodies the elegance of biological engineering.
Indeed. Well, let's waste no time and truly unpack this marvel. To genuinely appreciate the elbow's function, we must first build from its foundational structure. Could you begin by painting a detailed picture of the bones and the specific articulations that intricately form this joint? What makes it unique?
Absolutely. The elbow at its core is scientifically classified as a trochoging limamus joint. Now, that might sound like a bit of a mouthful, I know.
It does, rather.
But it's crucial because it describes its sophisticated dual functionality. It combines a hinge-like action, what we term jingly-moid motion, allowing for the familiar flexion and extension.
Right, the bending and straightening.
Exactly. And it combines that with a distinct rotational capability known as trochoid motion, which enables pronation and supination of the forearm, turning the palm up and down.
Okay.
This sophisticated design is precisely what grants the elbow such an astonishingly wide range of utility in both precise, fine motor tasks and powerful, forceful movements in daily life and sport.
So it's that combination that's key.
It is. And within this structure, we identify three primary articulations working in concert. Firstly, and perhaps most prominently, is the ulnohumeral joint.
Okay.
This is the main hinge, formed between the trochlea of the humerus, that's the stool-shaped end of the upper arm bone, and the greater sigmoid notch of the ulna, the larger forearm bone. This is a remarkably congruous hinge joint.
Meaning they fit very closely together.
Exceptionally closely. It provides a substantial degree of inherent stability, almost like a meticulously crafted dovetail joint in fine carpentry.
Ah, good analogy.
Secondly, we have the radiocapitellar joint. This is where the capitellum, the lateral, sort of spherical part of the humerus, articulates with the radial head, the cylindrical top of the smaller forearm bone, the radius.
Right.
This joint functions primarily as a pivot joint, allowing the radius to spin during forearm rotation. It's considered a secondary stabilizer, but essential for smooth motion.
Okay, so less inherently stable than the ulnohumeral.
Correct. And finally, often overlooked perhaps in its importance, is the proximal radial nor joint. This is the articulation where the radius meets the ulna right up near the elbow.
Okay.
This joint is absolutely crucial for enabling the complex and extensive range of forearm rotation, allowing us to turn our palms up, supination, or down pronation. The congruity between these bone surfaces, particularly that highly stable ulnohumeral joint, is the primary reason the elbow boasts such remarkable inherent stability, resisting displacement even under significant loads.
That detailed breakdown of the articulations is incredibly insightful. It really clarifies how different parts contribute to different movements. But let's delve deeper into the individual bony components themselves. What are the most critical features we, as medical professionals, should be keenly aware of on the humerus, ulna, and radius? What subtle anatomical details here have profound clinical significance?
An excellent follow-up question, because the bony contours are not just cast as structures. They really dictate function and are critical landmarks for diagnosis and surgery.
Right.
Let's begin with the distal end of the humerus, the upper arm bone. Here, you'll observe two distinct articular surfaces. Medially, there's the trochlea. As I said, it's spool-shaped and articulates with the ulna.
The main hinge part.
Precisely. Laterally, the capitellum is more hemispherical and articulates with the radius. Now, the trochlea's unique design particularly its medial ridge being noticeably larger and more prominent than its lateral counterpart.
Okay.
That's directly responsible for the elbow's natural valgus carrying angle. That slight outward angle of the forearm when the arm is extended. We'll explore that a bit more shortly.
Oh, okay. I was wondering where that came from.
And the distal flare of the humerus, encompassing the medial and lateral epicondyles, is surprisingly substantial. It actually accounts for half of the entire elbow joint's width. These epicondyles serve as broad, robust attachment points for crucial ligaments and muscle groups.
Right. Lots going on there.
Now, here's a subtle but critically significant detail. The humeral articular surface isn't perfectly aligned with the shaft. It's tilted anteriorly by approximately 30 degrees relative to the humeral shaft.
30 degrees forward.
Yes. And it's also externally rotated by about 3 to 5 degrees relative to the posterior flat surface of the humeral shaft. This precise anatomical alignment, this subtle 30-degree anterior tilt and slight external rotation, is the secret handshake, if you will, that locks the elbow into surprising rock-solid stability in full extension.
Really? Just those few degrees?
Absolutely. It's a design marvel.
Yeah.
When compromised, say by a subtle malunion after a distal humerus fracture, even seemingly minor subsequent injuries can cause major instability. It just reveals how crucial those precise degrees truly are.
Fascinating.
Furthermore, on the humerus, you'll find the coronoid fossa anteriorly, which provides space for the coronoid process of the ulna during deep flexion,
Makes sense.
and the olecranon fossa posteriorly, which accommodates the olecranon process during full elbow extension. This allows for that impressive range of motion.
Okay, so that covers the humerus. What about the ulna?
Moving to the proximal ulna, its greater sigmoid notch forms a saddle-shaped ellipsoid articular surface. This notch is fundamentally comprised of the coronoid process distally and the olecranon process proximally, which together articulate snugly with the humeral trochlea.
Right, that big C shape.
Exactly. The sagittal ridge of the greater sigmoid notch is a key feature. It runs longitudinally and perfectly complements the apex of the trochlea, while the concavities medial and lateral to it receive the convex faces of the trochlea. It's a remarkable fit.
Okay.
Clinically, it's vital to remember that the articular cartilage surface here is quite thin, only about 2 to 3 millimeters thick.
Very thin.
Yes. And furthermore, it often has a common, normal discontinuity right at its center. Now, this can, in inexperienced hands, be tragically mistaken for a cartilage defect during arthroscopy.
Ah, a potential pitfall.
A crucial diagnostic pitfall for practitioners. The proximal ulna itself also exhibits a slight varus angulation of about 5-7 degrees relative to its shaft axis. This subtle angulation, combined with the humerus's trochlear shape, directly contributes to that carrying angle we mentioned.
All right.
Its sagittal plane orientation is also about 30 degrees posterior to the long axis of the ulna, which beautifully complements the humerus's anterior tilt, further enhancing the elbow's stability and extension.
Does it work together?
Perfectly. Finally, the lesser sigmoid notch, located laterally on the coronoid, is where the radial head articulates, facilitating that forearm rotation.
Okay, and the radius itself.
And finally, the proximal end of the radius. This features the cylindrical radial head, which articulates with both the capitellum of the humerus and the lesser sigmoid notch of the ulna.
Right.
A critical surgical detail here. The hyaline cartilage covers approximately 240 degrees of the radial head's rim, leaving a bare, cartilage-free area of about 120 degrees.
A bare area. Why is that important?
Well, this bare area is of immense clinical utility for orthopedic surgeons. It represents a safe zone for hardware placement during the fixation of radial head fractures.
Ah, so you can put screws there without damaging the joint surface.
Precisely, ensuring that screws or plates don't impinge on the crucial articular surface and compromise motion. Furthermore, there's a specific and essential 15-degree angle between the radial head and neck and the long axis of the radius.
15 degrees. Seems small, but this angle is absolutely essential for enabling the forearm's impressive range of rotation, pronation, and supination while maintaining consistent articulation with the capitellum. Even a minor abnormality in this angle, perhaps from a malunited fracture, can profoundly impair forearm rotation.
Wow.
And distal to the radial neck, the prominent radial tuberosity serves as the important distal attachment site for the powerful biceps brachii tendon. These intricate bony details are truly the foundation of the elbow's remarkable function.
An excellent point. While the bony congruence provides foundational stability, the capsulogamentous structures are the true passive soft tissue stabilizers. Think of them as robust, strategically placed cables, providing critical support and dictating the limits of motion.
Okay.
Let's explore these essential restraints. First, and arguably the most talked about in clinical circles, is the medial, or ulnar, collateral ligament, widely known as the MCL.
Right, the MCL, very common injury in throwing athletes.
Extremely common. This ligament originates from the anteroinferior aspect of the medial epicondyle of the humerus and inserts onto the sublime tubercle of the medial coronoid process of the ulna. It's not just a simple band, though. It's a complex structure composed of three distinct bundles: the anterior, posterior, and transverse bundles.
Three parts to it.
Yes, the anterior bundle is by far the most critical component. It acts as the primary restraint against valgus stresses. That's any force attempting to push the forearm outward, away from the body's midline, like in a throwing motion. And it does so throughout the entire arc of elbow motion. Its anterior fibers remain taut in extension, while its posterior fibers become taut in flexion. Its clinical significance is so profound that it's often likened to the anterior cruciate ligament, the ACL, of the knee.
Really? That important?
That important, yes.
Yeah.
Given its crucial role in preventing instability, particularly in overhead athletes, a vital surgical consideration is that its humeral origin is located precisely at the elbow's axis of rotation, which is a key principle for successful MCL reconstruction procedures.
Right. Getting that placement spot on is critical.
Absolutely.
Yep.
The posterior bundle of the MCL serves as the primary restraint to valgus stress, specifically when the elbow is in maximal flexion. Now, if this bundle becomes contracted, which can happen after prolonged immobilization or trauma, it can severely limit elbow flexion, often necessitating surgical release to restore the full range of motion.
Ah, I see. And the third bundle?
The transverse bundle, sometimes referred to as Cooper's ligament, runs between the coronoid and olecranon. However, it's generally inseparable from the joint capsule and is considered to be of lesser significance for overall joint stability compared to the other two.
Okay, so the anterior bundle is the main player medially. What about the lateral side?
Good question. Next, we turn to the lateral collateral ligament complex, or LCL. This complex originates from the posterior lateral epicondyle, specifically an isometric point on the lateral aspect of the capitellum.
Isometric meaning its tension stays relatively constant.
Correct. It maintains relatively uniform tension throughout the elbow's flexion and extension arc. This complex comprises several vital components: the lateral ulnar collateral ligament, LUCL, the radial collateral ligament, RCL, the annular ligament, and an accessory collateral ligament.
Quite a few components there.
It is a complex. The LUCL is the most clinically relevant component of the lateral complex. It is the primary restraint to varus stress, that's force pushing the forearm inward, and also restricts excessive external rotation. It inserts robustly onto the crista supinatoris of the proximal ulna, a bony ridge.
Okay.
Its deficiency, often occurring after elbow dislocations or sometimes aggressive surgical releases, is a common and debilitating cause of posterolateral rotatory instability.
That sounds nasty. What exactly happens there?
It's where the radius and ulna literally sort of twist or subluxate away from the humerus, leading to a recurrent painful clunking or even frank dislocation. It's a significant problem.
Right. And the other LCL components?
The RCL inserts into the annular ligament and functions primarily to stabilize the radial head. The annular ligament is a fascinating, crucial ring-like structure. It completely encircles the radial head, maintaining its intimate contact with the ulna and providing essential stability to the proximal radial narrow joint.
Holds the radial head in place during rotation.
Exactly. Its anterior insertion tightens in supination, while its posterior insertion tightens in pronation, accommodating the radial head's non-spherical shape and ensuring continuous articulation. The accessory collateral ligament further stabilizes the annular ligament, particularly against varus stress, adding an extra layer of passive support.
Okay. So we have MCL medially, LCL complex laterally. What about the capsule itself?
Finally, yes, we have the joint capsule. This robust fiber structure completely encloses the joint, creating a sealed compartment containing synovial fluid for lubrication and cushioning.
Essential for smooth movement.
Absolutely. It attaches precisely to the articular margins of the bones and is intricately connected to the annular ligament. The anterior capsule becomes taut when the elbow is in full extension, helping to limit hyperextension, while the posterior capsule becomes taut in flexion.
Okay.
The joint is maximally distended at approximately 70-80 degrees of flexion, capable of holding roughly 25-30 milliliters of fluid. Now, its individual contribution as a passive stabilizer is somewhat debated. Yes, Some studies suggest it contributes relatively little to joint laxity after a complete capsulotomy, while others report it provides perhaps up to 15% resistance to valgus stress and full extension.
Yeah.
Regardless, it certainly plays a vital role in overall joint integrity, fluid containment, and proprioception of the joint's sense of position.
Right.
Together, these static structures, the MCL, LCL complex, and capsule, form an incredibly robust network that ensures the elbow's remarkable inherent stability.
That's an exceptionally clear breakdown of the static stabilizers. It highlights just how critical these seemingly taut bands are. But a living joint isn't static, is it? It's constantly moving, bearing dynamic loads, responding to forces. How does the body add active responsive stability to this already robust framework? That's where the muscles step in, right? Could you elaborate on these dynamic stabilizers?
Precisely. While static restraints provide that essential foundational support, the muscles crossing the elbow joint are indispensable dynamic stabilizers. Their brilliance lies in their ability to adapt. When these muscles contract, they don't just generate movement, they apply a continuous compressive load across the joint.
Ah, so they squeeze the joint together?
Effectively, yes.
Yeah.
This joint compression dynamically stabilizes the elbow, protecting the static ligamentous constraints from excessive, potentially damaging stresses, particularly during forceful or repetitive activities. We can broadly categorize them into four main groups.
Okay.
Firstly, the flexors. These are the muscles responsible for bending the elbow. The primary elbow flexors are the biceps brachii and the brachialis muscle. The brachioradialis also provides significant assistance in flexion, especially during rapid movements.
Right, the main bending muscles.
Exactly. The distal attachment of the biceps is at the radial tuberosity, making it also a powerful supinator, as we'll see. The brachialis attaches about 11 millimeters distal to the coronoid tip. All these key flexors are innervated by the musculocutaneous nerve.
Okay, flexors covered.
Next, we have the extensors. The undisputed principal extensor is the triceps brachii, but we must also mention the anconeus muscle.
Anconeus, I remember that one. Small muscle.
Relatively small, yes. Though it plays a minor role in direct extension, its primary significance from a stability perspective is its action as a crucial dynamic constraint against varus and posterolateral rotatory instability.
Really? How does it do that?
It helps to pull the ulna laterally and posteriorly, sort of tightening things up on that side, preventing that subluxation we talked about. It's often overlooked, but important in complex instability.
Interesting. Okay, extensors. What else?
Then, the supinators. These muscles rotate the forearm to turn the palm upwards. Surprisingly, the biceps brachii is responsible for the majority of forearm supination strength, especially against resistance.
So the biceps does flexion and supination.
Yes, a very versatile muscle. It's powerfully assisted by the supinator muscle itself, which wraps around the proximal radius.
Got it. And the opposite movement.
And finally, the pronators. These perform the opposing action, rotating the forearm to turn the palm downwards. The key muscles here are the pronator teres and the pronator quadratus. Pronator teres is more active in rapid or resisted pronation, while pronator quadratus is active in all pronation movements.
Well,
the beauty of the elbow's dynamic stability lies in the precisely coordinated action of these muscle groups. They don't just move the joint, they provide continuous active compression and protection. Think of them as living shock absorbers and tension bands.
right.
This dynamic stability is absolutely critical in preventing injuries, particularly in high-impact sports or activities requiring high loads and repetitive movements. Understanding their individual contributions is vital for effective rehabilitation.
That's a truly comprehensive picture of the structural and dynamic components, but as we know, the elbow isn't an isolated entity, it's a crucial conduit. What about the critical neurovascular structures, the nerves and major blood vessels that traverse this incredibly busy region? Their precise pathways are surely of immense clinical importance.
You've hit upon a critical point. The elbow region is indeed a high-traffic anatomical corridor, teeming with major nerves and blood vessels, supplying the entire forearm, wrist, and hand. A nuanced understanding of their precise pathways and potential vulnerabilities is absolutely vital.
Especially for surgery or managing trauma.
Exactly. Vital for avoiding iatrogenic injury, diagnosing nerve entrapments, planning safe surgical approaches. Let's first map out the nerves.
Okay.
The musculocutaneous nerve primarily innervates the biceps and brachialis. At the elbow, it exits laterally, just distal to the biceps tendon, and then becomes the lateral antebrachial cutaneous nerve, LABC, providing sensation to the lateral forearm. You'd find it typically running between the biceps and brachialis in the upper arm.
Okay, musculocutaneous.
The radial nerve has a fascinating journey. Proximally, it's in the spiral groove of the humerus, about 13 centimeters proximal to the trochlea. It then pierces the lateral intermuscular septum about 7.5 centimeters above the trochlea. As it descends toward the elbow, it lies between the brachialis and brachioradialis, and distally, it's quite superficial to the joint capsule.
Making it vulnerable there.
Very much so, especially near the radiocapitellar joint, susceptible to injury from distal humerus fractures or doing lateral surgical approaches.
Right.
The median nerve courses predominantly medially with the brachial artery. In the upper arm, it typically crosses from lateral to medial relative to the artery. At the elbow, it lies superficial to the brachialis. Critically, while it gives small branches to the joint, its major motor branches to the forearm arise just distal to the elbow.
Okay, median nerve. And the ulnar, the funny bone nerve.
Precisely, the ulnar nerve. It runs initially medial to the brachial artery, then pierces the medial intermuscular septum, often at the arcade of Struthers, entering the posterior compartment. Its most well-known course is traversing directly posterior to the medial epicondyle, through the confined cubital tunnel.
Where it's easily compressed.
Exactly, making it exquisitely vulnerable to compression or direct trauma, leading to cubital tunnel syndrome. Like the median nerve, it gives small branches to the joint, but its first major motor branch, usually to FCU, is distal to the elbow.
Got it. And the blood supply.
Regarding the blood supply, the principal vessel is the brachial artery. It's medially located in the upper arm and enters the cubital fossa, that triangular space on the front of the elbow laterally.
What's in a cubital fossa?
Critically, from lateral to medial, the biceps tendon, the brachial artery, and the median nerve, remember tendon, artery, nerve.
Okay.
At the elbow level, just distal, the brachial artery typically bifurcates into the radial and ulnar arteries, supplying the forearm and hand. There's also an extensive anastomotic network of collateral branches around the elbow, like the superior and inferior ulnar collaterals.
Meaning there are backup routes for blood flow.
Precisely. This rich collateral supply is why severe arterial injury at the elbow doesn't always lead to immediate limb ischemia, though their integrity is critical in trauma.
Okay, that covers the crucial wiring and plumbing. We've meticulously built up a picture of the elbow's static and dynamic components. But now comes the incredible part. How do all these individual structures truly interact to create the fluid, complex motion we rely on every day? Let's talk about the elbow in action, its kinematics.
This is indeed where the elbow's true ingenuity shines. The kinematics reveal how this complex system delivers its remarkable range of movements. Despite its complex classification, the elbow joint primarily facilitates two main degrees of freedom, each with its own precise axis of rotation.
Two main types of movement.
Yes. Firstly, flexion and extension, the bending and straightening. The normal range is quite extensive, typically 0 degrees full extension to an average of 145 degrees for full flexion.
Though there's variation.
Oh, absolutely. Hyperlax individuals might hyperextend 10 degrees or more. Conversely, bodybuilders, due to muscle bulk, might only reach 130 degrees. But from a practical perspective, the functional range is key.
What's needed for daily life?
Research shows that for most activities, eating, dressing, hygiene, a range of approximately 30 to 130 degrees is entirely sufficient.
So you don't necessarily need the full 0 to 145.
Not for most basic tasks, no.
Sure.
The axis of rotation for flexion and extension isn't a simple fixed point. It's centered primarily at the trochlean capitellum, often conceptualized as a line from the capitellum to the antero-inferior medial epicondyle.
Okay.
And while we often simplify it to a pure hinge, sophisticated studies show subtle movements 3 to 4 degrees of valgus laxity and axial laxity during flexion. There can even be individual variations of up to 8 degrees in the precise location of the screw axis.
That sounds complicated. Why is that important?
Recognizing these nuanced movements has been profoundly instrumental in designing better, less constrained elbow implants for total elbow arthroplasty, aiming to replicate more natural kinematics.
Ah, for joint replacements. Makes sense. Okay, flexion extension. What's the second degree of freedom?
Secondly, pronation and supination, the intrinsic rotation of the forearm itself. Normal range for supination palm up averages around 85 degrees, slightly more than the average 80 degrees for pronation palm down.
And the functional range here?
Similar to a flexion extension, for most daily activities, a functional range of about 50 degrees of pronation and 50 degrees of supination is generally considered sufficient.
Okay.
The axis of motion for pronation and supination is unique. It runs longitudinally from the center of the radial head capitellum proximally, down through the wrist to the base of the distal ulnar styloid distally. It's oblique, and crucially, forearm rotation is largely independent of the elbow's flexion extension position.
Right.
an intriguing detail. The radius actually translates proximally by about 1 to 2 millimeters with pronation. This subtle shift can increase the radiocapitellar joint reaction force, which, perhaps surprisingly, contributes to overall valgus elbow stability.
Compresses the joint a bit more.
Exactly.
Yeah.
Clinically, it's paramount to recognize that while you might be able to partially compensate for a loss of pronation by internally rotating your shoulder,
Okay.
there is very little effective mechanism to compensate for a significant loss of supination.
Mm-hmm.
Preserved supination is particularly vital for tasks like eating or turning a doorknob.
That's a really important clinical point. You mentioned the carrying angle earlier. What exactly does it signify, and how does this anatomical detail contribute to the elbow's function?
The carrying angle is indeed fascinating and clinically significant. It's formally defined as the valgus angle, the outward angle formed by the long axis of the humerus and the long axis of the ulna when the elbow is fully extended and the forearm fully supinated.
So when your arm is straight, palm forward, the forearm angles out slightly.
Precisely. That angle is your carrying angle, normal range. Typically 5-10 degrees for males, slightly greater for females, usually 10-15 degrees.
Why the difference?
It's partly attributed to the broader pelvis in females, necessitating a slightly greater angle to ensure the arms clear the hips comfortably during walking. This angle diminishes significantly as the elbow flexes, virtually disappearing around 90 degrees.
And anatomically, it comes from the trochlea.
Primarily, yes. As I mentioned, the medial ridge of the trochlea is larger than the lateral ridge, causing that natural 5 to 7 degree valgus tilt at the ulnohumeral joint itself.
Functionally, why have it?
It's thought to facilitate efficient movement, like swinging the arms during walking, and allows for efficient carrying of objects slightly away from the body. However, deviations from the norm excessive valgus, cubitus valgus, or a varus angle, cubitus varus, forearm angled inward, can have significant clinical implications.
How so?
Abnormal angles lead to altered joint mechanics, uneven stress distribution. Excessive cubitus valgus increases stress on the MCL, potentially leading to overuse injuries. Cubitus varus increases loading on the lateral side, contributing to conditions like osteochondritis dissecans or instability. So it's a critical indicator of mechanical health.
That distinction is so important. It really hammers home how every degree matters. This raises a crucial question. How do these meticulously shaped bones and that complex network of soft tissues work together to maintain stability throughout this wide range of motion, particularly under dynamic forces?
This is the crux of the elbow's biomechanical marvel. It's one of the most inherently stable joints, a testament to the interplay between the highly congruent articular surfaces and the robust soft tissue constraints. It's a balance between mobility and stability.
How do we categorize the stabilizers?
We typically classify them into primary, secondary, and dynamic constraints.
Okay, primary first.
The primary static constraints provide the most significant immediate passive stability. These include the ulnohumeral articulation itself, especially the robust coronoid process of the ulna acting as a buttress against posterior dislocation.
Right, the bony fit.
Absolutely. If you lose more than 50% of the coronoid height from a fracture, stability is severely compromised. Also, primary are the anterior bundle of the MCL, the powerhouse resisting valgus stress, and the LCL complex, providing primary restraint against varus and external rotation.
Okay, those are the big three static ones. What about secondary?
The secondary static constraints augment this, acting as crucial backups. These include the radiocapitellar articulation, a vital secondary constraint to valgus stress, especially if the MCL is torn.
So the radial head helps the MCL.
Exactly. Also, the common flexor and extensor tendons, which provide some passive support, and the joint capsule itself.
And the dynamic ones.
The dynamic stabilizers are, of course, the muscles crossing the elbow joint. They provide continuous compressive forces, acting like active tension bands, protecting the static restraints. The anconeus, for instance, is a key dynamic constraint against varus and posterolateral instability.
Right, the active muscle control. How do these contribute under specific stresses?
Good question. For varus stress, inward force. In full extension, the bony joint articulation provides about 55% of stability, the anterior capsule about 32%, and the RCL about 14%. At 90 degrees flexion, the joint articulation becomes even more dominant, providing about 75% of stability.
So the bones are key for varus stability.
Very much so. For valgus stress,
Yep.
outward force. In full extension, stability is remarkably balanced, almost equally divided among the MCL anterior capsule and bony articulation, roughly a third each.
Interesting.
However, at 90 degrees of flexion, the MCL truly emerges as the primary workhorse, providing approximately 55% of the stabilizing contribution. This explains why it's so frequently injured in throwers.
Peak stress position.
Exactly. When considering distraction, pulling apart forces, in extension, the anterior capsule provides about 85% resistance. At 90 degrees flexion, the MCL takes over, providing about 78%.
Okay.
And it's crucial to highlight the synergistic relationship between the MCL and the radial head. MCL is primary against valgus, but the radial head is a vital secondary constraint. If both are damaged, you get gross instability.
Like the ACL and meniscus in the knee analogy you mentioned.
Precisely. A combined injury is much worse. Finally, the impact of forearm rotation on stability is highly significant clinically.
How so?
Studies show that with an MCL deficiency, the elbow is more stable in supination. Conversely, an LCL deficient elbow is more stable in pronation. And with coronoid fractures, the elbow is also more stable in supination.
That's fascinating. Why does that matter?
It's vital for guiding optimal positioning during injury management, casting, bracing, and rehabilitation after complex injuries or reconstruction, aiming to maximize stability during healing.
That's a masterful explanation of stability. Given the powerful movements and forces involved weightlifting, throwing there must be significant internal forces passing through the joint. What does our understanding of these forces tell us?
You're absolutely right. The forces are considerable. This is partly due to the relatively short lever arms of the muscles. The biceps, for example, inserts close to the center of rotation, meaning it needs to generate very large internal forces to produce movement. This leads to large joint reaction forces.
Which can lead to wear and tear over time.
Regrettably, yes, contributing to degenerative changes like osteoarthritis. Looking at axial loading. In an extended elbow, about 40% of the load goes through the ulnohumeral joint, but 60% goes through the radiocapitellar joint.
60% through the radiohumeral joint.
Yes. This uneven loading helps explain why radial head fractures are so common after falls onto an outstretched hand. The brunt of the impact goes there. It also helps understand why injuries there often lead to persistent pain or arthritis.
Right.
Interestingly, the greatest internal forces occur between 0 and 30 degrees of flexion and during pronation. Paradoxically, as the elbow flexes more, the moment arm of the flexors increases, so even though greater strength can be generated, the actual contact forces across the joint are often less in deep flexion compared to near extension.
That's counterintuitive.
It is. A critical biomechanical insight is that the line of action of both flexors and extensors inherently generates a posteriorly directed force component.
Pushing the forearm backwards relative to the humerus.
Essentially, yes. This explains the tendency toward posterior displacement in severe injuries and contributes to loss of fixation in surgically repaired distal humerus fractures. The muscles actively try to pull the fragments posteriorly.
Challenging the repair.
Exactly. Furthermore, uneven stress distribution is a major driver of long-term pathology. If contact pressure shifts towards the joint margins, you get significantly higher concentrated stresses in localized areas. This is often seen in chronically unstable or incongruous joints and is a direct precursor to chronic pain and accelerated arthritis. Understanding these forces is essential for guiding reconstruction, implant design, and rehab.
That's a powerful insight into the internal stresses. It makes clear that precision is paramount. This biomechanical understanding must directly translate into surgical approaches, right? For instance, what's the optimal position for elbow arthrodesis, fusing the joint?
Indeed, biomechanics are paramount here. Elbow arthrodesis aims to fuse the joint in a position offering the best possible functional outcome.
So what position is that?
For a unilateral arthrodesis, one elbow, the optimal position is typically considered 90 degrees of flexion, with 0 to 7 degrees of valgus.
Why 90 degrees?
It represents a functional compromise. It allows for a wide range of essential tasks, bringing food to the mouth, writing, some self-care, manipulating objects at waist height. It balances reaching the face with interacting with the environment.
Okay. What if both elbows need fusing?
In the challenging cases of bilateral arthrodesis, the strategy adapts. Often, each elbow is fused at a different angle. For example, one elbow at 110 degrees of flexion to facilitate self-feeding.
Right, reaching the mouth.
And the other elbow fused at a more extended angle, perhaps 65 degrees of flexion. This is strategically chosen to enable essential personal hygiene, particularly perineal care, which needs a longer reach.
A very thoughtful, tailored approach.
Absolutely. It highlights how biomechanical understanding directly translates into patient-centric decisions with monumental impact on quality of life and independence.
Professor, we've journeyed through the incredible design in biomechanics. But like any complex system, it's susceptible to injury. What are the most common elbow injuries we encounter, particularly in a professional medical context?
It's true. The elbow's mobility, its role in powerful activities, and its exposed position make it prone to a wide range of issues, from acute trauma to chronic overuse.
What are the main categories?
First, fractures. Exceedingly common, especially in children, about 10% of childhood fractures, typically from falls or direct impacts. Common types include supracondylar fractures in kids or olecranon and radial head fractures in adults. While many heal with casting, accurate diagnosis and appropriate care are crucial.
Okay, fractures. What else?
Then dislocations, often high-energy injuries from blows or accidents causing joint misalignment, often present with visible deformity, demand prompt reduction and management of associated ligament or nerve injuries, which are frequent.
Right, need putting back in place quickly.
Sprains and tendon injuries are extremely prevalent. Sprains involve ligament damage, notably the MCL, from impacts or repetitive stress, like the Tommy John injury in throwers.
Yes.
Among tendon injuries, lateral epicondylitis, or tennis elbow, is archetypal. Chronic pain on the outside, affecting forearm extensor tendons, and overuse syndrome not just for tennis players.
Right, very common.
Its counterpart is medial epicondylitis, or golfer's elbow. Pain on the inside, affecting flexor pronator tendons, also overuse. More severe are distal biceps avulsion or triceps rupture, which usually need surgical repair.
Okay, other common issues.
Olecranon bursitis, student's elbow. Inflammation of the bursa at the elbow tip, caused by repetitive motion, trauma, or critically, infection which presents as warm, red, painful swelling. Needs rest, ice, anti-inflammatories, or antibiotics if infected. Surgery is a last resort.
Right, infection is key there.
Cubital tunnel syndrome. Compression of the ulnar nerve behind the medial epicondyle. Causes characteristic numbness tingling in the little and ring fingers, often weakness wasting. Exacerbated by elbow bending. Treatment ranges from conservative measures to surgical decompression.
Okay.
We also see osteochondritis dissecans affecting cartilage and bone, particularly the capitellum in young throwers. And finally, elbow stiffness and contractures, often from chronic issues, immobilization, trauma, or arthritis. The posterior MCL bundle can become contracted in flexion contractures, limiting extension.
That's a comprehensive list. Recognizing these quickly is key. Beyond history, what are the immediate telltale symptoms a patient might present with that signal a significant elbow injury? What are the initial red flags?
Prompt recognition is vital. Patients often report a constellation of signs. Common red flags include sudden, intense pain, sharply localized or diffuse, often with visible bruising and significant inflammation, swelling, and warmth.
Classic signs of acute trauma.
Exactly. A hallmark sign is limited range of motion, struggling or unable to fully flex, extend, pronate, or supinate. Could be pain, mechanical block, swelling, or muscle spasm. Always compare to the other side.
Comparison is key.
In some cases, particularly fractures or loose bodies, patients might report crackling or grinding sounds, crepitus during movement, indicates rough surfaces or fragments.
Okay.
For severe injuries like dislocations or displaced fractures, there may be a striking visible deformity. The elbow looks obviously out of alignment. That's an orthopedic emergency.
Needs immediate attention.
Absolutely. Finally, neurological symptoms are critical. Numbness and tingling in the arm or hand, often in a specific nerve distribution, like the ulnar pattern and cubital tunnel syndrome, indicates nerve compression, stretch, or trauma. Any combination of these warrants thorough evaluation.
Those are clear red flags. Beyond symptoms, how do clinicians precisely assess and diagnose these? What's involved in a comprehensive physical exam, and when do imaging studies come in?
A systematic assessment is the cornerstone. It starts with a comprehensive patient history, delving into the mechanism of injury, onset, nature, location of pain, previous issues, activities, what makes it worse. Then an initial assessment of range of motion, strength, stability. Crucially, evaluate the shoulder and wrist, too, for referred pain or compensatory movements.
Don't just focus on the elbow itself.
Correct. For the physical examination specifics, observation is key. Swelling, bruising, deformity. Always compare to the contralateral side. Palpation involves applying direct pressure to pinpoint tenderness, differentiating inflamed tendons, torn ligaments, fractures. Specific maneuvers include stress tests. For example, a valgus stress test applies outward force to the forearm to check MCL integrity. Pain, excessive gapping, or a clunk is positive.
Testing the ligaments directly.
Yes. Similarly, a varus stress test checks lateral stability, Clinicians also identify the lateral soft spot formed by the lateral epicondyle olecranon radial head, a safe entry point for injections.
Okay. When is imaging needed?
Imaging studies support clinical findings. X-rays are usually the first step, excellent for bone visualization, revealing fractures, dislocations, bone spurs. Multiple views are standard.
Right.
Magnetic resonance imaging, MRI, provides detailed soft tissue images. Invaluable for ligament tendon disorders, assessing tear severity, detecting subtle cartilage damage. An arthrogram, contrast dye injected before MRI, can enhance visualization of ligament tears.
For more detail on soft tissues.
Exactly. Computed tomography, CT scans are less common for general issues, but superb for defining complex bony structures in 3D. Indispensable for highly comminuted fractures or planning intricate surgical reconstructions.
For complex bone detail.
Precisely. Ultimately, the diagnosis often relies heavily on amalgamating clinical findings. For common conditions like lateral elbow tendinopathy, diagnosis is often clinical unless fracture instability is suspected. Key symptoms like pinpoint pain on pressure and discomfort during specific loading activities are crucial. Similarly for golfer's elbow, it's a meticulous puzzle putting all the pieces together.
So, what does this all mean for us? We've truly journeyed through the incredible, often underestimated complexity of the elbow, its nuanced bony architecture, intricate ligaments, powerful muscles, precise biomechanics, and sadly, the common ways it can go wrong.
Indeed. Our discussion today unequivocally underscores that a profound, deep understanding of the elbow's anatomy and biomechanics isn't just academic, it is absolutely critical. An indispensable foundation for effectively diagnosing, treating, and preventing the wide array of pathologies affecting this vital joint.
Right.
This knowledge directly informs every single decision, from physical examination, imaging interpretation, surgical reconstruction of ligaments or bones, fracture fixation techniques, to the visionary design of future arthroplastic components, all aiming to restore normal kinematics and load-bearing capacity.
Allowing patients to regain function.
Exactly. Understanding why it's built the way it is and how it operates is the only way to truly fix it when things go wrong.
It's not just knowing the parts, but understanding their symphony. And for you, our dedicated listener, we sincerely hope this deep dive has offered those truly insightful aha moments, giving you a comprehensive yet accessible understanding to take directly into your practice, inform your patient discussions, or simply satisfy your immense curiosity. If you found this discussion valuable, please do consider rating and sharing this deep dive with a colleague who might also benefit from these insights. It genuinely helps us reach more curious minds like yours. Thank you for joining us on the deep dive. Until next time, keep exploring, keep questioning, and keep learning.